from BJ Medical College, Ahmedabad. After that, he has completed his MD Medicine from BJ Medical College only. Then he has done his MD Cardiology from UN Mehta Institute of Cardiology and Research Center from 2016 to 2019, sir. Apart from his academic, sir, he has been having an experience as an consultant cardiologist in cardiac science department at Zydus Hospital, Anand, sir. That one is his present affiliation, sir. As far as his experience concerned, he has a senior resident doctor in interventional cardiology at UN Mehta Institute of Cardiology and Research Center from 2016 to 2019. Dr. Himanshu Meghnathi has been achieved many feather. He has been honored as an NH Patel Gold Medal in securing highest mark in DM Cardiology in Gujarat University. The another one golden feather he has achieved as Sri UN Mehta Gold Medal for securing highest mark in DM Cardiology at BJ Medical College, Ahmedabad. And third and most, Dr. Shranik Shah Gold Medal for securing highest mark in theory and practice in DM Cardiology at Gujarat University. He has been awarded as a gold medal as IAMICON Award 2019 for academic as well as research excellence in the field of cardiology, Gujarat State. And won a first prize for best oral paper presentations at AMCEMT Annual Conference 2016. Apart from his achievements, sir, he has been published many research papers, and the most important paper is Efficacy and Safety Profile of Pulmonary Vasodilator Therapy in a Patient of COPD associated with Pulmonary Arterial Hypertension. Many papers which has been published. One of them is paper and study which has been published in Journal of Indian Heart Association 2019, sir, and many more. So it is an opportunity to have words from you, sir, with this digital platform. And sir, I am handing over dais to you, sir, please.
Hello, good evening, everyone, and thank you for this brief and in a very detailed description for me. I welcome you all for this webinar. That is the platform provided by JB Chemicals. Nowadays, the webinars are definitely increasing, and I'll try to make this as informative and as detailed and clinically important as possible for your clinical practice in this era of COVID-19. So let's not waste any more time, and let's get into the topic of today's discussion, which is cardiac care in this era of COVID-19. We are going to discuss in this outline. Initially, we'll discuss that COVID-19 and what is the level of myocardial injury it causes. Then we'll discuss about role and significance of various biomarkers, that is troponin, BNP and NT-proBNP, D-dimer, role of cardiac imaging in COVID-19 patients, management of STEMI and NSTEMI, role of therapeutic and prophylactic anticoagulation, and then management of pulmonary embolism and some other elements like arrhythmias, various drug interactions, and so on. So as we know that COVID-19 is caused by a SARS-CoV-2 virus. It is a coronavirus, novel coronavirus, which is of family of SARS, and it causes primarily a lung infection. It affects lung by mechanism and receptor endothelization of ACE2 receptor. So it basically attaches to ACE2 receptor, and then it gets internalized, and then there will be cellular replication of virus, and particularly it affects lung. Okay, so after this, this ACE2 receptors are not just present in lungs, they are present in cardiac tissue as well as renal tissue. So this virus causes cardiac involvement by over and above by two mechanisms. One is direct toxicity, one is indirect toxicity. So what is the direct toxicity? So ACE2 receptor is present on myocardial cells. SARS-CoV-2 gets attached with this ACE2 receptor, and causes myocarditis and inflammation of myocardium, which is eventually may convert into fulminant myocarditis and leads to heart failure. So this is the direct toxicity of SARS-CoV-2 virus. What is the indirect toxicity? So it basically causes lung infection. Lung infection will lead to inflammation. Inflammation leads to cytokine storm, which is basically imbalance between various inflammatory markers like interleukins, cytokines, and various molecules of T cells, B cells, and macrophages. So this immune activation, sudden immune activation will lead to cytokine storm, which leads to endothelial injury. Now, endothelial injury is a baseline mechanism for almost all major complication of coronavirus. It causes in a way, it causes endothelialitis. So there is a obstruction of microvessels, even coronary artery, and some even macrovascular complications or macrovascular thrombosis. And all of this ultimately either leads to acute coronary syndrome, or it may lead to pulmonary embolism, or some cases of DVT also. So this is over a general mechanism by which SARS-CoV-2 affects heart. If we see that here, that COVID-19 virus, it causes direct toxicity of myocardial cells, which is direct infection and myocarditis. Even though this mechanism is still not fully established that it is directly causing myocarditis, but there are some evidence which is suggesting some autopsy studies which has suggested that COVID directly affects these myocardial cells. Majority of its effects comes from systemic inflammation. If you see that systemic inflammation ultimately leads to thromboembolism, some arrhythmias secondary to myocarditis, acute coronary syndrome, heart failure, and acute cardiac injury. So systemic inflammation is the main cause of COVID-19 related heart diseases. Now, underlying comorbidity like hypertension, diabetes, obesity, metabolic syndrome, or all this comorbidity predisposes heart to get affected. If you have this particular comorbidities, the patients getting worsening of this corona virus disease chances are more. Now, these are the possible mechanism, theoretical possible mechanism of myocardial injuries. As we have discussed, majority of this mechanism are this, as if you can see this red marker, it is systemic inflammation, systemic inflammation, systemic inflammation. All of this causing myocardial infarction, either heart failure or some kind of arrhythmia. Okay. Second most common mechanism is sympathetic stimulation. Once lungs get infected, there is a role of there is a milieu of sepsis. With this sepsis, there is hypoxia, sepsis, increased heart rate. All of this causing supply-demand mismatch. Supply-demand mismatch means there is increase in the oxygen demand, and with that there is hypoxia, which causes decrease in the supply. All this again leads to myocardial infarction or eventually LV dysfunction, which leads to heart failure. So main mechanisms are inflammation, second is sympathetic stimulation, and other other mechanism is direct myocardial involvement, which is represented here with this yellow marker, that either myocarditis or direct myocardial infarction or myocarditis, it will lead to either heart failure, infarction, or arrhythmia. Now, if you see the prevalence of either cardiovascular diseases or any cardiovascular risk factors like hypertension and diabetes, so majority of the patients who are in ICU setup or on ventilator, the prevalence of cardiovascular diseases are around 19 to 25 up to 30%. So majority of these patients have some kind of underlying cardiovascular disease. If you see the comorbidities, hypertension has been present in various studies from 20 to even 58% of the patients. Some of the initial studies are from China, and then secondary studies from Italy and USA. One of a large study included at least 44,000 patients. Diabetes is also around 20 to 25% patients had diabetes. So cardiac risk factors or underlying cardiovascular disease is a well-known risk factor for patient getting very critically ill with this COVID-19 infection, and there is a probability that they will require ventilation or ICU. Now, let's get to the myocardial injury. Now, it has been postulated that it causes myocardial injury by various mechanisms, as we have discussed, that it can be supply-demand mismatch, it can be direct myocardial toxicity, or it can be myocardial infarction. So what is myocardial injury? Myocardial injury is nothing but there is some kind of damage to myocardium. Whenever there is myocardial damage, there will be release of troponin. This troponin, if can be detected in blood just above 99 upper reference limit, 99% upper reference limit, that means just detectable range. If it is detectable, by definition, you can say that there is ongoing myocardial injury. Now, this myocardial injury doesn't mean the patient have myocardial infarction. Myocardial injury means some kind of damage to myocardium has occurred. It can be from various mechanisms, as we have discussed. Okay. So now, if you see that what is the prevalence of this myocardial injury, so various studies have postulated that this prevalence is around 36%, which is a very large percentage. Many patients with COVID, at least 36% of the patients with COVID-19 are having some kind of myocardial injury. This, again, I'm saying it doesn't mean myocardial infarction, it's just some kind of myocardial injury. So what kind of myocardial injuries it can be? So there are basically three types of myocardial injury. One is chronic myocardial injury. Second is acute but non-ischemic myocardial injury. And third is acute myocardial infarction. We are very familiar with acute myocardial infarction, but these two terms are chronic myocardial injury and acute non-ischemic myocardial injuries are relatively new to define. So what is chronic myocardial injury? It means that there is a chronic stable increase in troponin I, but this increase has never reached up to 20% change. So there is some baseline troponin, and then it slightly gets elevated, but it doesn't reach more than 20% from baseline. It never reaches that level. That means some underlying chronic myocardial damage is occurring. Now, why such kind of injury should occur? It can occur due to patient is having old age, there is supply demand mismatch, there is underlying coronary artery disease, which is because of that there is some flow reduction in particular vascular bed, and because of that there is some myocardial damage. So chronic myocardial injury are not severe, and it may occur because of hypotension, sepsis, direct supply demand mismatch, because heart rate is suppose the patient is having heart rate of 120, 130. With that, there is also hypoxia of 80, 90% of SpO2. So at this hypoxia, at this level of oxygen, patient's heart, which is contracting at the rate of 120, 130, doesn't get enough oxygen. Because of that, there is some underlying myocardial damage, which leads to this chronic myocardial injury. What is acute non-ischemic myocardial injury? It means basically the name itself suggests that it's non-ischemic in nature. That means that there is no blockage in particular coronary arterial bed. So what is it? So how we differentiate it from chronic myocardial injury? So chronic myocardial injury, the baseline change should be less than 20%. If there are dynamic rising and falling troponin concentration, which is more than 20%, and with that, there is no evidence of myocardial ischemia. How do you define myocardial ischemia? By ECG or echo. If there are changes of ischemia on ECG, then it will be defined as a myocardial infarction. But baseline ECG is normal, the echo is normal. Still, there are there are ongoing rise or fall in troponin I. Then it is defined as acute non-ischemic myocardial injury. We'll get into the causes of each and why it occurs. And third part of that myocardial injury is acute myocardial infarction. Now, acute myocardial infarction is defined as basically there are two types of acute myocardial infarction. One is with what we commonly see up to now, what we used to see, that acute myocardial infarction is due to there is some underlying atherosclerotic plaque. It get ruptures, and then there is a thrombosis of that vessel. That vessel got completely blocked, and there is ST elevation myocardial infarction. This ST elevation myocardial infarction is called type 1 acute myocardial infarction. Second type of myocardial infarction is supply demand mismatch. Because there is underlying chronic cardiovascular disease, that coronary artery disease. Patient is having triple vessel disease, but it was having just angina. Patient doesn't have any evident myocardial infarction. But with this underlying CVD, patient gets COVID. Because of that, there is hypoxia, there is hypotension, there is tachycardia, there is sympathetic stimulation. All this associated with coronary artery disease causes some kind of myocardial damage. This is known as type 2 acute myocardial infarction. Now, if we logically think that that patient is having COVID and there are multiple coronary risk factors, then possibility of type 2 AMI in particular patients of COVID are relatively higher, because it is easy to get hypoxia in COVID, easy to get tachycardia, easy to get sympathetic stimulation. So type 2 myocardial infarctions are relatively common in these patients. Now, how do we define this myocardial injury and what needs to be done? So usually myocardial injury is defined as we have seen that there is a rise in the troponin markers. If the troponin markers are raised, then you can definitely say there is myocardial injury is ongoing. But it doesn't mean there is myocardial infarction, because it's just a part, myocardial infarction is a part of that spectrum. And just elevation of troponin I doesn't define the patient is having acute myocardial infarction. So in this era of COVID, biomarkers has become easily available, and interpretation of these levels of biomarkers are being difficult. So this saying goes very well over here, that muddy water, let stand, becomes clear. That if you let it stand, the muddy water will eventually become clear because the sedimentation will occur. So in cardiac biomarker, this will also again suffice that if you let it stand, most of them will become clear. It will become normal in majority of patients. So first marker we are going to discuss is troponin I. So first chart, okay, this chart suggests that from number of patients who are having troponin elevation. So very large number of patients, nearly 1200 up to 800 had minimal elevations of troponin I, while these higher levels 0.25 to 0.75 were very less frequently seen in very few patients, few number of patients. These high numbers of troponin was seen. So you can definitely eliminate this patient, very minute elevation in troponin I. So it will often, and majority of patient will resolve this troponin I. Okay, so no need to worry about minute elevation of troponin I. It may occur because of, as we have discussed, multiple mechanisms, and it doesn't confer the diagnosis of infarction. Now, if you see over here that majority of these patients will have troponin elevation in first few days. This is from days of admission. On 0 day, on the day of admission, majority of had troponin elevation. Eventually, as the day passes, this troponin elevation goes down. Okay, and even larger elevations were also seen in initial days, only in initial, on the day of admission. As the day passes, these elevations will eventually resolve in majority of patients. So again, let it stand, it will clear. If it is significant, if it is clinically significant, patient is having some symptoms, there are ECG changes, there are some echo changes, and then you need to worry about this troponin elevations. Now, then what is the role of doing these biomarkers? Is there any role of diagnosis of this particular markers? We have seen that this elevation in biomarker may be due to n number of reasons, because of supply demand mismatch, because of direct toxicity, because of acute myocardial infarction. So there are many reasons that troponin may get elevated. So what is the role in diagnosis? Not so great role in diagnosis. Then what is the role? That is relevant when you compare it different outcomes. So here is a chart. It is outcome class. If the elevation was in the range of 0.00 to 0.03, the mortality was very less. Mortality was, this red part is basically mortality. So mortality was very less. When you compare various range of 0.03 to 0.09, the mortality increases. And in patients who had more than 0.09 nanogram per ml troponin, the mortality is quite significant. So as the value of troponin increases, this mortality rate increases. Here is a Kaplan-Meier chart of saying the same thing, that as the troponin level increases, the survival chances decreases. This red chart is basically troponin level of more than 0.09. So survival was nearly 40% in these patients, while if the patient's troponin was in the range of 0.03, survival was nearly 80%. Okay, so troponin have some prognostic information rather than diagnosis. It has a better prognostic marker. This is the same chart saying nearly same story, that this is the hazard ratio of 3. Hazard ratio of 3 means patient with a particular value are 3 times at more risk compared to baseline value. So with troponin of more than 0.09, patients are at risk more than 3 times than normal patients of COVID. So if you take patients subset who are having a normal or 0.03 troponin, and you take another subset in which the troponin level is more than 0.09, this subset is at least 3 times at risk for particular worse outcome. Okay. This is again a chart. Right now we have we didn't discuss about the absolute value in terms of absolute value, but here if we see that HS trophy value and mortality relation, so from days of onset of illness from 0 to 22, the patient who survived had nearly similar level of troponin. Their troponin didn't increase, but the patient who were non-survivor, who didn't survive this, the troponin level keep on increasing, and on the day of 22 it reaches up to nearly 300 level. Okay, so as the troponin increases, chances of non-survival, chances of worse outcome, chances of death increases. Here another chart which is showing the same thing, that mild COVID, the troponin elevation is in the range of 20. But as the COVID gets severe, or there is myocarditis, Takotsubo shock, or type 1 myocardial infarction, the troponin value increases up and sometimes above 200. So its absolute value and the relative value gives overall information about prognosis. If the value is very high, then it definitely confers worse prognosis. If the troponin is increasing, then also it confers worse prognosis. So this is the overall discussion on troponin, which suggests, which we have said that that rise or fall on troponin is definite of myocardial injury, but it is not sufficient to secure the diagnosis of myocardial infarction. It just suggests that some kind of myocardial injury is ongoing. It doesn't mean there is myocardial infarction. So how do we diagnose myocardial infarction with troponin? That you need to have some other like echocardiography, some angiographic or ECG evidence. Then and then you can say that patient is having myocardial infarction. Okay, so this was the discussion on troponin. Now another biomarker is BNP and NT-proBNP. Now NT-proBNP is basically a marker of heart failure. NT-proBNP of more than 900 is usually suggestive of acute LV failure, acute heart failure. But in COVID patients, they have suggested that even minute elevations of NT-proBNP is associated with worse survival. Here if you see that this is a survival chart, and this dotted line is NT-proBNP level of less than 88, and this hard line is NT-proBNP level of more than 88. So if you can see that at the end of 15 days, nearly less than 40% of patients survived who had NT-proBNP of more than 88. So this, if this chart is converted to ROC chart, you can see that NT-proBNP level with cutoff of 88 had sensitivity of 100% to diagnose possibility of in-hospital death. What does this mean? That majority of patients who dies of COVID will have elevation of NT-proBNP of more than 88 level. So if the NT-proBNP level is less than 88, you can say the patient will have a fairer prognosis, better prognosis. If the patient is having NT-proBNP of more than 88, then there are chances that patient may get percent. It doesn't mean that patient will have in-hospital death, because the specificity is around 66% only, but it is definitely sensitive. So it can be used eventually. This is a smaller study. It is very difficult to extrapolate this data to a larger population, but it definitely gives some idea that if the patient's level of NT-proBNP is less than 88, he or she will have a fairer or better prognosis. This is from the same study. If you now, if there will be some issues that if the patient have older age or any severe infection or increased CRP or adjust with myocardial injury, then whether this NT-proBNP give similar information or not. So they adjust this data for sex and age, CPK-MB level, troponin level, with various creatinine level, WBC level, and PCT and CRP. Among all this adjusted data also, NT-proBNP fare well. That means the hazard ratio is more than 1. Hazard ratio more than 1 means from baseline or baseline characteristic, NT-proBNP of more than 88 have worse prognosis. So even despite adjustment from all these parameters, NT-proBNP did give good information regarding prognosis of patient. That means it's an independent marker of prognosis. This is the third biomarker that we are going to discuss. First was troponin, second is NT-proBNP, and third is D-dimer. Now D-dimer is regularly being done in COVID patients. It basically, COVID is now established coagulopathy. It is a definite, it's one of definite mechanism for pathophysiology is various type of endovascular thrombosis. So D-dimer is a marker of thrombotic and coagulant and procoagulant marker. Now D-dimer, what kind of information does it give? It again a prognostic marker, and it gives information regarding the prognosis of patient. Here, if you can see that ordinary group were an improved group and poor outcome group, they were compared. So D-dimer value of 0 to 8. Initially, it was in the range of 8 to 10, and with the increase in the day, the D-dimer came to normal in improved group. While in poor group, baseline D-dimer was more than 20. It was more than 20, and it never reached near normal level. It was within the 2 to 3,000 level. So D-dimer baseline increase in the D-dimer on the first day of admission, it gives information regarding prognosis. If you see this D chart, that stage 1 of COVID disease, stage 2 of COVID, and stage 3 of COVID. This is ordinary patients, orange is improved patients, and black marker is poor patient. In poor patient, from stage 1 to stage 3, there was increase in D-dimer. While in ordinary patient, D-dimer remained nearly static and below 1. While in improved patient, it was initially high, but eventually decreased. So rise in D-dimer will give information regarding possible poor prognosis of patient. If the D-dimer is keep on increasing, that means the disease is getting worsened. If the D-dimer is decreasing, you can confer from that patient's disease is improving. Now, this was overall discussion about troponin, NT-proBNP, and D-dimer. These are the main cardiovascular related biomarkers that are regularly used from various for cardiac disease, heart failure, pulmonary embolism, acute myocardial infarction, NSTSES. For all these markers are regularly used, and they basically give some prognostic information for COVID patients. Now, the topic of discussion comes to cardiac imaging. Now, cardiac imaging can be 2D echocardiography and CT coronary angiography, or CMR, that is cardiac magnetic resonance imaging, cardiac MRI. Now, the various guideline has suggested that you should not perform transthoracic echocardiography in all patients of COVID-19. It is not indicated that all patients should undergo some kind of echocardiography. Even the patients who are having troponin elevation, that means myocardial injury, they don't necessarily require echocardiography. If there is a chance that doing echo will change the management strategy, if you are suspecting that there is troponin elevation, along with that there are ECG changes, and you need to see if the patient is in definite heart failure, and you need to see the ejection fraction of that patient, and doing echo will change the management strategy. In those cases, only echocardiogram should be done. Now, that means that you should have a probable thinking or probable thing or possible diagnosis in mind, what you want to see in that particular echocardiography. Okay. Now, transesophageal echocardiography is nearly contraindicated because it just increase the risk of spread of COVID-19 by aerosolization. So it is not indicated at all. Now, this echocardiography should be focused or focused. What is this? What does this mean? Now, point of care ultrasound or focused cardiac ultrasound study. It means a small instrument should be there, and you just see that what is the ejection fraction of patient, is there any fluid, how is the valvular status, and just get on with. You don't need very detailed echocardiographic parameters, that what is the wall thickness and what are other things like strain imaging and contrast imaging. It is not needed. Just do echo fast and you get out of it, and you just get whatever information you want from this focused or focus echocardiography. So this is bedside echocardiography is indicated in patients whom the test result should change management strategy. Now, for CT angiography and cardiac MRI, now as we have seen that there are patients who will not have myocardial infarction despite troponin elevation. So there is disparity. There is ECG is normal or echo is normal, while there is elevation in troponin I, and you want to rule out coronary artery disease, you can do CT angiography, because invasive coronary angiography will again expose more to the cath lab staff and cardiologists. So if the probability of having a myocardial infarction is low and troponin elevation seems due to myocardial injury or myocarditis, CT angiography can be done to rule out coronary artery disease. Second need of CT angiography comes in ruling out pulmonary embolism. There is elevation of D-dimer, there is RV strain, RV dysfunction, and the patient is having other clinical signs and symptoms of pulmonary embolism. Then CT angio should be done to rule out pulmonary embolism. In cardiac, and for particularly cardiac MRI, acute myocarditis, to rule out it from MINOCA, that is myocardial infarction with non-obstructive coronary artery. Because of some microvascular dysfunction, patient may have myocardial infarction. Though the main larger coronary arteries are normal, the microvascular dysfunction can cause myocardial infarction. This will lead to LV dysfunction. So LV dysfunction basically have 2 or 3 differential diagnoses in patients of COVID. One differential diagnosis would be acute myocardial infarction, but you would know from ECG and echo that patient is having acute myocardial infarction. Now, if the ECG and echoes are normal and still there is troponin elevation and there is a LV dysfunction, then what are the differential diagnoses? Then it can be acute myocarditis, MINOCA, or Takotsubo syndrome, that is stress cardiomyopathy. These all can be differentiated with the use of cardiac MRI. Once again, it should be done only if the diagnosis will change your management strategy. Just to expose, just for the sake of diagnosis, the CMR should not be done. Now, let's get into the major part of this discussion, which is the management of STEMI and NSTEMI. So until now, we have discussed that myocardial injury is quite easily possible in these COVID patients, and it is also a procoagulant and very thrombogenic, high thrombogenic risk status. So there are chances of high risk of ACS in these patients. So how would you diagnose ACS STEMI or NSTEMI in the patients of COVID? Which the answer is the routine, our routine diagnostic approach, which is history and physical examination. there should be an ECG which is showing that there is definite myocardial infarction of particular territory like RVMI, inferior wall MI, anterior wall MI. So that should be evident on ECG. There should be biomarkers which confer that there is ongoing myocardial injury, and you can do focused echo to suggest that there is a definite regional wall motion abnormality. Then ECG is suggestive of anti-wall MI, and on echo there is anti-wall hypokinesia is there. So this is the diagnostic approach for the STEMI patient, because troponin elevation you will see in many patients. There has to be some other evidence like ECG and echo to label the patient as STEMI or NSTEMI. Now, what to do when such patients comes to ER? So first, you just rule out your screening process. By your screening process, that patient is having fever, respiratory symptoms, history of contact. If that is not there, then probability of patient having COVID is very less. You do it according to your routine protocol. If there is a possibility of COVID infection, then you go through your screening protocols. Like if you are doing HRCT, then you do that. If you are doing RT-PCR, you send that. And if the patient requires admission, then you admit the patient in a particular flu corner or emergency department where you routinely do the screening and do the first line investigation, which is ECG, echo, and biomarkers. This was the ER thing. Now in the ER, now you have diagnosed the patient that ECG is suggestive of anti-wall MI. There is a possibility that patient may have COVID, and echo is also suggestive that there is anti-wall MI to the patient. That means the patient is definitely a case of STEMI. Now the patient of STEMI during this COVID-19 pandemic, what should we do? Whether now the management is like any other patient only, any other STEMI patient. The guideline doesn't change if the patient have COVID and STEMI together. The primary PCI is still the gold standard for the patient with STEMI, irrespective of their COVID-19 status. If the patient comes to a hospital where there is a 24/7 cath lab services, then primary PCI is the first line treatment. If the patient is at without cath lab services, then you should go ahead with fibrinolysis. Now the door to balloon time or door to needle time, that has been relaxed because you need to screen the patient, you need to prepare the PPE and all the setup, and you need to prepare the cath lab staff, equipments, everything. So the door to needle time may get delayed nowadays in this COVID-19 pandemic, but the definite treatment is for sure primary PCI. So STEMI management doesn't change from the basic guideline of routine STEMI patient. Now, if you see that the STEMI characteristic in COVID-19 patients are definitely different from the routine patients. And this chart suggests that if the stent thrombosis are quite significantly higher seen in this COVID-19 era. Multivessel thrombus. Usually, when you get anti-wall MI, you expect that there will be a thrombus in LAD artery, left anterior descending artery. But in COVID era, you are getting multivessel thrombus. The thrombus, even despite anti-wall MI, the thrombus may be in circumflex artery or right coronary artery. If you see that non-COVID patient doesn't get such kind of presentation. Modified thrombus grade 4 or 5, that is large thrombus burden. So COVID patients are definitely having a larger thrombus burden. Fourth parameter is myocardial blush. Myocardial blush is basically a parameter of reperfusion. Grade 3 blush, that means it is very good reperfusion has been done. So in COVID patient, the reperfusion are not very ideal. Reperfusion, even despite doing a primary PCI, the blush level doesn't reach up to the 3 level. And D dimer is quite high in this COVID-19 patients. So these are the STEMI characteristic we are getting in this COVID-19 patient. Patients are having a high thrombus burden, multivessel thrombotic diseases, and also the efficacy of primary PCI is slightly lesser than a routine non-COVID patient. Now, for STEMI, we definitely say that primary PCI is the rule. It is the gold standard treatment. But from NSTEMI doesn't go ahead with the routine guideline. For NSTEMI, there are different gray zones. So if the patient comes to you with NSTEMI and there is a possibility the patient may have a COVID-19 disease, then if the patient is very high risk or high risk, then you should go ahead with invasive strategy. Invasive strategy, that means coronary angiography and angioplasty. So what are these high risk features? That if the patient is in shock, ongoing chest pain, recurrent chest pain, any mechanical complication, if the patient is having heart failure, and intermittent elevation is also there. This is very high risk patients, and immediate invasive strategy like PCI should be done. If there is dynamic STT changes and recurrent symptoms, and with that troponin elevation, these are high risk patients, and once you should get a COVID report, you should get early invasive strategy with doing the PCI within less than 24 hours. Now the patient who are at intermediate risk or low risk, that means they are not having these parameters. In those cases, you should go ahead with non-invasive testing. You shouldn't directly just go ahead with coronary angiography. Let the COVID settle. If the patient is at intermediate or low risk, you just start on anticoagulant, antiplatelet, and then after the part of COVID management is over, you can go ahead with angiography and angioplasty. But initial period, you can definitely go ahead with non-invasive strategy. So there is definite some change in NSTMI management in this COVID-19 outbreak. Now, third part, that is, first part was marker injury and biomarkers. Second is management of ACS. Third part is COVID-19 and coagulopathy. Now, as we have discussed multiple times, that it is a coagulopathy. There is total derangement in the coagulation profile of patients who are having COVID-19. Now, the patients, what are the risk factors that are predisposing to the patients for this coagulopathy? That majority of patients who are getting sick, they are bedridden. There are some genetic factors. There is ongoing sepsis, some kind of liver and kidney injury, heart failure. These are the possible risk factors that patient may have due to for coagulopathy. Now, second point is inflammatory response. Now, COVID is causing systemic inflammation and eventually cytokine storm. There is lymphopenia, inflammatory cytokine is increased, interleukins are increased, CRPs are increased, other inflammatory markers are increased. All of them causes endothelial dysfunction. Endothelium dysfunction is a part of virtuous triad. Virtuous triad is for prothrombotic state. Basically, if there is a fulfillment of this triad, then there will be definitely a thrombosis or embolism. So there is definitely an endothelial dysfunction is ongoing in COVID patient. COVID-19 has been labeled sometimes endothelialitis. So there is an inflammation directly of endothelium. Now, all this leads to microthrombi, intravascular coagulopathy, myocardial injury, increase in the cardiac biomarker, the D dimer will increase, PT will increase, there will be a change in the level of platelet. This all hemostatic abnormality creates a milieu for thromboembolism, and clinical outcomes are VTE, that is deep venous thromboembolism, which is DVT or pulmonary embolism. There will be some myocardial infarction and occasionally DIC. So COVID causes some coagulant factor abnormality, endothelial dysfunction, and ultimately will lead to venous thromboembolism, myocardial infarction, or DIC. Now, this was the study done recently and published in JAMA. It had nearly 3,000 patients. So the study was to rule out, to detect how many episodes of thrombotic event occur in routine patients. So all hospitalized patients, ICU and non-ICU, the numbers were 3,000. So incidence of pulmonary embolism was nearly 3%, DVT again same, stroke same, MI at least 9%. Overall, any thrombotic event occurred at the frequency of 16%. 16% patients, all all admission patients, out of COVID patients, 16% had some kind of thrombotic event. If you see particularly ICU patient, that this event rate goes up to 29. So patients with COVID who are admitted in ICU or requiring oxygen or some kind of ventilation are at higher risk for development of any thrombotic event, because there is ongoing more inflammation, more endothelialitis, more procoagulant factors, and eventually more thrombosis. So there are at least 30% patients within ICU had some kind of thrombotic event. If you see here that in patients who ICU, the initial D-dimer level was around 1700 and it reached up to the maximum of 10,000. In non-ICU patient, initial level were around same, but never reached the maximum level of D-dimer. And the patient who had some kind of thrombotic event were definitely had higher D-dimer level than the patient who didn't have any thrombotic event. So D-dimer again, as we see that it confers prognostic, it is a prognostic marker and suggests the probability of patient getting any thrombotic event. So now we know that the patient are at risk for any thrombotic or venous thromboembolism type of episode. So we require some kind of treatment for that. So what is the treatment? That is thromboembolism prophylaxis, VTE prophylaxis. So all the patients who are admitted with mild COVID, mild, moderate, or severe COVID within ICU or even in room, the patient should be started on prophylactic anticoagulation therapy. We'll get into the proper protocol, but from this we can see that the patient with COVID have some kind of coagulation abnormality and they require some kind of anticoagulation. Now, whether we should give prophylactic anticoagulation doses or we should give therapeutic coagulation doses, we'll discuss in some next slides. Now, this was the study that was done in USA, which compared the patient who were not given any anticoagulation and the patient who were given therapeutic anticoagulation. So this is a Kaplan-Meier chart of survival. And if here you can see that the blue line had lower survival rate compared to red line. The red line suggests that patient who were on anticoagulation. So here you can see that from all patient admission, all admissions, not just ICU patient, all patients who were admitted in hospital, those who were not given anticoagulation had worse prognosis than those who were given anticoagulation. Now here we are comparing the patient who were on mechanical ventilation. So here you can see this without anticoagulation had worse prognosis than patients who were on anticoagulation. So this is a clinical trial suggesting the benefit of usage of anticoagulation. Now, the VTE, venous thromboembolism, will eventually, this DVT will eventually cause pulmonary embolism. There were multiple autopsy studies that has suggested that pulmonary embolism is one of major cause for death in patients of COVID. The first cause is pneumonia and extensive parenchymal damage to the lung tissues. Second cause is pulmonary embolism. Now, what is the evidence? What is the incidence of this pulmonary embolism? This was the one study in which at least 24% incidence of pulmonary embolism was seen in patients of COVID-19 pneumonia. And in ICU patient, the incidence of pulmonary embolism was 50%. In 50% of the patients who were in ICU with COVID-19 were having pulmonary embolism. It may be subsegmental or microvascular pulmonary embolism, but there were imaging evidence of pulmonary embolism. This was a study from Europe. Now, this another study, this was a larger study, French multi-center cohort study, in which at least 3,000 patients was admitted and at least 1,240 patients were underwent CT pulmonary angiography. In this, 8% of the patient had pulmonary embolism. This is a larger study. This one a smaller study. But in ICU patient, there was definite increased incidence of pulmonary embolism in this study of Europe. While in this French study, the overall incidence rate was 8.3%. So many patients of COVID-19 pneumonia are getting pulmonary embolism. Now, what are the prediction rate that patient will have pulmonary embolism? So male sex is one of significant risk factor. Yes, you can see that p-value is very small. That means it is significant risk factor for development of pulmonary embolism. Age, smoking, malignancy, venous thromboembolic disease, they didn't have any significant comparative value for prediction of pulmonary embolism. But time from illness to onset of hospitalization, that the day disease start and you went to get hospitalized, as it increased, the chances of pulmonary embolism increased. So the basically the negligence of from patient side, or ignoring the major symptoms, it definitely increased the chances of pulmonary embolism. Increase in CRP was associated with significant more chances of pulmonary embolism. And here you can see the hazard ratio is more than 1 in this zone. Here it is less than 1. That means that these two factors were associated with lesser chances of pulmonary embolism. What are these two factors? Prophylactic dose of anticoagulation and therapeutic dose of anticoagulation. Means the patient who were on anticoagulation had lower chances of developing pulmonary embolism. So now we have seen statistics that there are definite evidence that pulmonary embolism occurs in the patients of COVID-19 pneumonia. Its rate varies from 8% to 30%, and anticoagulation helps in preventing this pulmonary embolism. So ultimately, it was eventually multiple societies of this management of COVID-19 has decided that patients should be given anticoagulation. Various societies differ among the what kind of dosage should be used. This is particularly that is followed in US and Australia and some parts of Europe, that what kind of dosages should be given to the patients who are having who are admitted for COVID-19 pneumonia. So all patients of COVID-19 positive admitted to the hospital should receive anticoagulation unless contraindicated. If there are definite ongoing bleeding or specific contraindication, then patient should not be given anticoagulation. Otherwise, all patients who are admitted in hospital should be given anticoagulation prophylaxis. So now let's see here. So critically ill patients. What are the critically ill patients? Okay, there is ongoing evidence of thrombosis. There is worsening of hypoxemia on X-ray. There is D-dimer level of more than 5,000, or there is increasing D-dimer, rapidly increasing D-dimer. If any of these are present, then patient should be given therapeutic anticoagulation. If it is not there, then high-dose prophylactic anticoagulation should be given. Now we know that routine prophylactic dose for anticoagulation is 0.4 mg per kg for enoxaparin. High-dose prophylaxis is particularly recently started in various trials, that enoxaparin should be given at the rate of 0.5 mg per kg in these COVID patients. Okay, so if the patient is not falling in this any of these three category, then high dose prophylaxis should be given. If any of the patients are falling in this category, patient should be given therapeutic anticoagulation, which is 1 mg per kg BD for enoxaparin and 18 unit per kg per hour for heparin. Now many studies has been done that and it has proven that heparin efficacy decreases in COVID-19 infection. More than routine dosages should have to be given to maintain the APTT level or activated clotting time level for heparin. So if you are using heparin, you may need to give a larger dosage than the routine dosages that you are giving in routine patients. So you need to monitor APTT or any ACT to know that this heparin you are giving is in effective dosages, or you can just give enoxaparin. Now, in critically ill patients, direct anticoagulants or warfarin should not be given. You should give enoxaparin only in those patients. Now, the patients who are not critically ill, who are in ward, then you can just give in prophylactic dosages. Okay. Uh, After this, extended thromboprophylaxis up to 45 days post-discharge is advised in these patients of COVID-19 pneumonia. So what is the drug or agents that can be used for this extended thromboprophylaxis? The rivaroxaban 10 mg OD or enoxaparin 40 mg SCOD can be given. You should need to you need to give the dosages according to creatinine clearance. So overall here you can see that all patients who are hospitalized should receive some kind of anticoagulation prophylaxis. If the patient is critically ill, very high D-dimer, worsening hypoxemia, ongoing thrombosis, then patient should be given therapeutic anticoagulation. If such things are not there, but still patient is critically ill, some on oxygen, or there is a D-dimer high, but not up to the level of 5,000, then you should give high dose prophylaxis. And in those patients who are not critically ill, who are in ward, then you should just give routine prophylactic dosages. And in those patients, or in all of these patients, you need to give some extended thromboprophylaxis post-discharge in form of rivaroxaban or enoxaparin. Now, we are leaving this procoagulant and coagulation profile part also of our discussion and reaching the arrhythmia part. Now, arrhythmia has been multiple times discussed after the suggestion that HCQ and chloroquine and hydrochloroquine should be given for prophylaxis or treatment of this COVID-19 pneumonia. And particular discussion topic was QTC prolongation, because chloroquine, hydroxychloroquine, azithromycin, all of this drug causes QT prolongation. So what kind of strategy should be used for usage of this QT prolonging drug? So if the patient had any recent ECG in which the QTC was less than 500, then there is no need of any fresh ECG. Okay. Then if the patient doesn't have any history of structural heart disease, any history of arrhythmia, or any congenital acquired long QT syndrome or bradycardia, in those cases, there is no need of fresh ECG. Okay. Now, if any of this thing is there, or there is no any ECG available, then you need to do one ECG. And if this ECG is performed and QTC is found to be more than 500, or in white QRS or LBBP pattern, if the QTC is more than 550, then you need to evaluate the risk-benefit ratio of starting this chloroquine and hydroxychloroquine drug in this patient. Now, we know that many studies have shown that HCQ and chloroquine doesn't give any benefit to the patients of COVID-19 pneumonia. And if the patient's baseline ECG is having QT prolongation, then you should not go ahead with and starting this drug and confer the patient probability of developing any arrhythmia. So in those patients, you should evaluate the risk-benefit ratio. Now, other than that, if the baseline ECG is performed and there was no QT prolongation, okay, then you can just start this COVID-19 medication. You should get one ECG after this starting day. After the starting medication, on the next day, you should get one ECG, and the QTC is normal, then no further ECG is needed. If on the second day, the ECG is done and there is a QT prolongation of more than 500, or any ventricular premature beats, or difference of QT, that is baseline QT minus present QT, if it is more than 60 milliseconds, then again you need to reconsider this, that whether the patient require this QT prolonging drug as much to take such a risk of developing arrhythmia. Okay, so one ECG should be there. If it is normal, you just start COVID-19 medication, you do another ECG, and if you see that there is any QT prolongation, then you should stop those drugs. If the QTC is normal on the second ECG, you don't need to do another ECG further on. Now, let's talk about this drug and their arrhythmogenic potential. Now, chloroquine and hydroxychloroquine we are using for years. Chloroquine for malaria, hydroxychloroquine for many rheumatoid arthritis and many connective tissue disorders. hydroxychloroquine has been regularly used. So why this the QT prolongation has been talk of the town? Because it, along with other medication, just increases a propensity of developing QT prolongation and chances of torsades. Overall, very low risk of torsades are there with chloroquine and hydroxychloroquine. But when you are using it in along with combinations like chloroquine, azithromycin, chloroquine, and steroids and everything, then there are slightly higher chances of such episodes. Azithromycin, overall, there is moderate to severe prolongation of QT, and there is a bit higher risk compared to HCQ and Q for torsades development. If you are using lopinavir, ritonavir, or tocilizumab, for tocilizumab, no particular ECG changes has been described, and the possibility of developing torsades is also very unknown. But these four drugs, CQ, HCQ, azithro, and lopinavir combination, are known to cause increase in the QT and possible risk of torsades. So if you're using these drugs in combination, then you should be very much has to be very much alert regarding development of prolongation of QT, and you should do the ECG. Now, for the COVID-19 therapies and anticoagulation interaction. So we now we have assured, make sure that patient of COVID-19 pneumonia requires some kind of anticoagulation, and you need to give COVID-19 therapies also. So what kind of effect these drugs causes on this anticoagulation drug? So chloroquine, HCQ, and azithromycin, all of them increases the level of NOACs. So if you are doing NOACs on OPD basis or at home therapy, and you are giving HCQ and chloroquine, then you need to be a bit alarmed regarding the possibility of bleeding chances. So particularly in patients who are having a decreased creatinine clearance, that is some kind of renal dysfunction, in those patients you need to be cautious, and NOAC should be used with cautious if you are giving these drugs along with NOAC and the creatinine clearance is very less. And in the patients who are having less than 30 creatinine clearance, use of dabigatran and azithromycin should be avoided. And if the creatinine clearance is less than 50, rivaroxaban should be used with caution. If the patient is having some bleeding risk, has platelet score of more than 3, in those patients, you shouldn't use such kind of combination. While other drugs like remdesivir, favipiravir, tocilizumab, perfenidone, methylprednisolone, they do not have any particular effect on NOAC, so it can be used along with NOAC easily without any interaction. So this was with the COVID-19 therapy and anticoagulation interaction. So overall discussion here is completed, and the take-home message I would say is that that myocardial injury is common in COVID-19, and it doesn't equal to myocardial infarction. It may be due to direct myocardial toxicity, it may be due to supply-demand mismatch, it may be due to sympathetic stimulation, it may be due to systemic inflammation. Any of many causes will cause myocardial injury and eventually troponin elevation. It doesn't require workup for coronary artery disease. Every troponin elevation doesn't require workup for coronary artery disease. Biomarkers help in prognosis rather than in diagnosis. So don't over-rely on them. Okay. So we have seen that troponin elevation, continuous increase in the troponin, all of them are associated with worse prognosis. D-dimer, baseline high D-dimer and increase in the D-dimer, both are associated with worse prognosis. Pro-BNP, anti-pro-BNP more than 87 has been associated with poor prognosis in the patient. So all of these markers helps in prognosis, but it doesn't give any diagnostic value. So don't over-rely on them. COVID coagulopathy is a rule rather than exception. All the patients develop some kind of coagulation abnormality. They have increased D-dimer, increased fibrogen degradation products, increased PT. So this is baseline coagulation parameters are abnormal in COVID patients very frequently. So you need to give some kind of anticoagulation. Now, prophylactic or therapeutic, it has to be decided on the basis of person to person. If the patient is having severe disease, ICU admission, very large value of D-dimer, then there is a need of therapeutic anticoagulation. If the patient is on room air and very stable, then just prophylactic anticoagulation can be given. Arrhythmia risk and drug interaction should be kept in mind while treating patients of COVID-19, because they have many inter-drug interactions and interactions with other anticoagulation drug. Thank you.
Right, sir. Thank you very much, sir. It was very lucid and very detailed presentations in a form of different biomarkers in current era of COVID, which we need to be taken care of in cardiovascular disorders. Now, certain questions which has been raised from audience, sir. Dr. Girish Thakkar raised question that when we should start anticoagulopathy treatment, especially in a patient who has been on home isolation, sir.
Now, as the protocol decided that majority of societies are following this protocol, and they advise the same, that patients who are admitted, that means that there is a requirement of admission, they should be started on anticoagulation. Now, if the patient is very stable, the D-dimer level is less than 500, patient is having minor symptoms like had a fever of 100 degree, occasional cough, the CT involvement is very less. In those patients, there is no guideline to start anticoagulation treatment. At home, there is no need to give this LMWH, enoxaparin, or even oral anticoagulation. It is not needed in the patients who are at home. If the patient is requiring some kind of hospital admission, that means that the D-dimer is above 1,000 or 1,500. Various studies has different cutoff. So ongoing studies are ongoing, that some are using the cutoff of D-dimer of 1,000. If it is more than 1,000, they want to start anticoagulation. Some are starting at more than 1,500 level. If some are starting, that patient requires oxygen, there is some kind of hypoxia and patient requires even O2 at 2 liter, they start enoxaparin. If the patient having any kind of dyspnea, CT involvement of more than 15 to 20, then in those patients, they advise anticoagulation. But patients who have very minute CT involvement, who are very minimal symptomatic, who are at very less chances of developing any of such complication, the D-dimers are normal, infective markers like CRP, all these are normal. In those patients, you don't need to start anticoagulation treatment.
Right, sir.
Hello. Neru bhai.
Yes, sir.
Dr. Himanshu, I have a simultaneously two questions. I am Dr. Devraj Dholaria from Surat.
Yes, sir. Please say.
Now you have said very nicely, acute non-ischemic myocardial injury. In these conditions, have any role of the HSCRP to detect the inflammation? Suppose the inflammation is the occult, so can the HSCRP may be the useful?
Yes, sir. Very good question. And recently, the same was the protocol for a study recently designed, that HSCRP is the COVID is basically an inflammatory milieu. So ongoing inflammation in the myocardium is ongoing. There are some kind of baseline endothelial injury, and endothelial injury will eventually leading to thrombosis events and episodes. So they studied the level of this HSCRP and the outcome. So HSCRP, whose HSCRP was elevated, in those patients there was definitely worse prognosis, and there were chances that patient may have some kind of plaque instability and acute myocardial infarction also. So HSCRP again here is having a prognostic role. If the patient's HSCRP baseline from baseline to right now, if it is increasing in trend, then you need to basically you just get aware that patient is a high risk patient or a fragile patient and may develop any coagulant or procoagulant complications.
Okay. And my second question is, you have nicely elaborated about the anti-pro-NB.
Yes,
now you have also said that the more than 80
Pro-BNP, yes.
The prognosis is the worst. But now the textbook, some textbook says that the normal value is the 125. So what is the
Yes, sir.
condition?
Now the NT-proBNP has been described from the value of 100 to 900. It is less than 100 is normal. 100 to 900 is a possibility of heart failure, and more than 900 is definitely heart failure. Until now, this was the value of all our NT-proBNP. Whenever we used to do NT-proBNP for heart failure, this was the value. Now, this study has totally different view of NT-proBNP. They basically said that their ongoing stress on myocardium will lead to minute elevation in this NT-proBNP level. Why it occurs? Because of there is endothelial injury in the lung, which is causing stress on the myocardium, even in atrium. That is causing release of NT-proBNP. So like HSCRP, which is basically a kind of CRP, and it is a minute level of, like we are doing troponin I and high sensitivity troponin I. So small elevations of this NT-proBNP from baseline were associated with worse prognosis. It is again a prognostic marker only, that if the patients, it have a rather rule out role rather than the rule in role. That means if the patient is having NT-proBNP of more than 88, it doesn't give much information. But if the patient's NT-proBNP is less than 88, you can be assured that patient is going to fare well, because no patient with less than 88 level of NT-proBNP developed any complication. So it has a good rule out role that patient, TMT is, suppose if patient is having chances that some coronary artery disease, we do TMT and patient's TMT is negative, overall risk factors are not there, then we can say that patient doesn't have any cardiac disease. So if the patient's NT-proBNP is less than 88, then you can be sure that patient's overall prognosis would be very good, rather than getting NT-proBNP more than 88 and suggesting to the patient that you will have worse prognosis.
Okay, thank you. Thank you, Himanshu.
Oh, thank you.
Right, sir. Any questions from audience?
Hello, Dr. Agrawal, sir.
Yes, sir, please.
આપણે સાઇટોકાઇન સ્ટ્રોમમાં સર
Yes, sir, please, sir.
સાઇટોકાઇન સ્ટ્રોમમાં IL-6 માર્કર વધારે ઉપયોગી છે કે CRP and ferritin combination?
Okay.
Overall, the IL-6 has a better prognostic value and the treatment modality wise, because it directly goes into the main mechanism of action, because IL-6 is the main molecule that is causing it. Now, CRP, HSCRP, ferritin are very non-specific markers that can be elevated in any inflammation, baseline infection, sepsis, hypotension. There are n number of causes that will cause this elevation in all these markers. While IL-6 is very specific, particularly for this immune dysregulation syndrome or cytokine storm that we are saying. So IL-6 has definitely a better marker for the cytokine storm.
બીજો સવાલ એ છે સર કે એક નેટ પર વાંચેલું કે કેન્સર થેરાપીમાં સાઇટોકાઇન રિલીઝ સિન્ડ્રોમ થાય છે તો એમાં પહેલા ટોસિલિઝુમેબ આપે છે, પછી એનો રિસ્પોન્સ નહીં આવે તો સ્ટીરોઇડ આપે છે. આપણા કોવિડમાં એવું જોવા મળે છે, પહેલા સ્ટીરોઇડ આપે છે, પછી રિસ્પોન્સ નહીં આવે તો ટોસિલિઝુમેબ આપે છે.
Yes, sir.
એના વિશે કંઈ કહેશો?
Now this thing is because we are getting into this COVID era. Nobody knew what the treatment is. We extrapolated many things from H1N1. What we used to do in H1N1, there was a possibility of H1N1 and eventually cytokine storm. We used to give high dose steroid, initially dexamethasone, then even methylprednisone, and we didn't reach even at that time to give tocilizumab. So in COVID-19, the chances and incidences of this cytokine storm are very higher than whatever we are getting in H1N1. So availability and efficacy, both thing matters, because steroid is very easily available. Now for these patients, with this number of patients, availability of steroid is very easy and it should be easily tried. and many even trials has suggested, even the US and UK trials, they both have suggested that the role of dexamethasone. Dexamethasone has been incorporated as a part of routine management of critically ill patients in all this COVID-19 who are requiring some kind of oxygen therapy or any mechanical ventilation. So it has been tried, studied, and effect was observed. So it was it became a part of management protocol. Now tocilizumab is the study is ongoing. One study came and it didn't give like extraordinary result. It had a equivocal result for the benefit. Now whatever many clinicians are using tocilizumab, and they are saying that they are getting good results with tocilizumab, but the randomized control trial didn't give any benefit to this tocilizumab agent. So if we see according to that steroid has definitely helped, and tocilizumab still we are equivocal. So it has to be decided on patient-to-patient basis. One of the reason we are giving more steroids and is definitely an availability of steroid and our routine experience with steroid. Tocilizumab has never been routinely used by any of us until now.
Right,
Thank
sir.
you, sir.
Any questions from audience, sir? Okay. Yes, sir, but it's overall a very lucid presentation, sir. And thank you very
Thank you,
much for
Dhirubhai.
sharing this digital platform with us. And finally, we got an opportunity to be associated with, with you, sir. Thank you, sir.
Thank you
Thank
so
you
much.
very much, sir.
Thank you, everyone, for being a part of this presentation. And it was a really nice discussion. Thank you, JB Chemicals, Nirobhai, for providing this platform to me.
Yes, always welcome, sir.
Thank you so much. And everyone, have a good night, everyone.
Yes, sir. Thank you, sir. Have a nice weekend, sir. Please.
Okay.
Thank you, Dr. Himanshu. You are from the Anand, and Anand is the home place for my study.
Oh,
okay. Okay, Devraj Sahib.
right, sir. Fine.
Before the 1980, I have completed.
Quite a senior to me,
Right,
sir.
sir. Fine.
And thank you for being a part and for your nice questions, sir.
Right, sir. Thank you, sir. Thank you all.
Okay, everyone.
Thank you, sir. Bye-bye,
Good
sir.
night. Goodbye.
Yeah, please.